Hi guys, I hope you had a great weekend. This is week 3 out of 15, and this is another video of mine. We're going to do what we usually do. I'm going to give you some feedback. I'm going to remind you what you have to submit by Sunday, and go over what we have for today, which is for this week, chapters 4 and 5. All right, so I'm gonna go ahead and share my Moodle site. There we go. So here we are. So what you submitted for last week was, and I have my notes here, LO 3, 4, 5, and 6. 92% the average for LO2, 93% for LO3, 82% for LO4, 92% for LO5, and 84% for LO6. Now, if you look close enough, the lower scores, the lower averages are for LO4 and LO6. So guess what they share in common? Both of those are from chapters from the GETP book, right? It looks like it's a little bit more challenging. So the LOs from the smaller book are a little bit more challenging. So I would suggest you spend a little bit more time and you study the material a little bit better before you take the LOs that are corresponding to chapters of that book, okay? And also it kind of makes sense to get higher scores in LOs that we have already covered last semester, right? Now, I want to address one item from LO5 that talks about the type of joint concerning the knee. So I mentioned that last semester, and it's a common mistake. I don't want you to get disappointed or anything. It's a common mistake. It's bicondylar, and it's bicondylar because it has 2 degrees of freedom. And we do the flexion extension, but there is a little bit of rotation. So that's why it has to do with 2, not just 1 that some of you think, right? So that's my general feedback about the LOs that were due on Sunday, last Sunday, the 14th, and today I'm covering chapter 4 and chapter 5, right? You have 3 LOs that you are submitting this week, LO 7, 8, and 9. No synchronous meeting. Yes, office hours tomorrow from 8 to 12:30. All right, I'm going to remind you about the office hours, hopefully, if I remember. At the end of this video, we have a lot to cover, and hopefully you remember a lot, and you need to study a little bit, all right? So these chapters have, that we're going to cover enough terminology in them, and it will require you to study by yourselves too, right? I can, as I've said before, I cannot cover everything in a 1-hour video, okay? But I'm here to help. Tomorrow I'll be here to help during office hours, and let me know if you need anything, okay? So I'm gonna stop sharing this, and I'm gonna share chapter 4. Hopefully, if I figured it out, let me see, there. All right, so health-related, let's see if this bad boy works. Yeah, all right, so health-related physical fitness testing and interpretation. We're gonna go over a couple of things that we have already covered, but I hope you remember that when we talk about physical fitness, we have the health-related components and the skill-related components. And the health-related ones are the ones that are required for everybody and are the ones associated with a ton of health benefits, okay? So that's why we care that much. And there is testing to figure out where we stand when it comes to health, those health-related components. And there's a way to interpret those scores that come from those tests. And that's what we're going to cover today. All right. So, as I said before, I hope you remember chapter 1, right? And as I said again, like a minute ago, we should focus on the health-related components of physical fitness. These are for everybody. The skill-related, not for everybody. The health-related are important for indicators that have to do with health and well-being. Okay. Now, one thing that you're gonna see in this book, and it's different from the previous version of GETP, is that now we don't have the normative data that we use from YMCA. Normative data, I hope you remember, they're data that have been created after we tested a lot of people, right? And then usually we'll have the normative, that normative data. What we're doing is we have your score and we compare it to a group that is similar to your sex and age, for example, right? And then by that comparison, we can say, you know, you are below average, above average, average, or whatever, and so on and so forth. So YMCA have stopped sharing their protocols the way they used to. And actually, our 2 years ago, our own lab was part of creating the new normative data for ACSM. So we tested 100 people, above 100 people, and we sent that data to ACSM to create their own normative data. All right. As I said before, they are compared to your age and your sex. So that is important. Of course, it is important to know where we stand before we start a program, right? And then we have follow-up tests to evaluate if our regimen is working or not. And if used appropriately, exercise testing can motivate people. Okay, and we've covered that last semester in PED214. Informed consent, we covered that. Exercise pre-participation health screening. Remember that? Chapter 2, right? Chapter 3 has to do the pre-exercise evaluation that has to do with cardiorespiratory cardiac risk, actually. 2.1 is the PAR-Q plus. And the participant instruction is another section that we already covered. All right, so basic principles, as you can see, make sure you have all the forms that are required before the testing and you're ready to administer it, right? The temperature is important, as you can see, humidity and airflow. Okay. Before you, let's say you are in an environment, in a lab that you perform tests, right? Whatever equipment you're using, that can be from, as you can see, a sphygmomanometer, treadmill, bike, calipers, anything, they have to be calibrated, right? So you have to make sure that 0 means 0. Like the equipment, you have to make sure that the scores you're getting are reliable, right? Or scale, for example. You have to calibrate it from time to time. Because if you don't, you're going to get error. Nobody likes error. That can mess up all your data set. Yeah, so concerning which measurements you should get first, a general rule of thumb is get those ones that don't affect the other ones. In the resting measurements, as you can see, heart rate, blood pressure, height, weight, body composition do not really affect if you do an 1RM test later on, right? The other way around, though, it's not the same, right? So we take these first, and then we move to the actual fitness tests. Now, concerning the fitness tests, ACSM is an organization that doesn't give you a specific order. But as you can see in that second dot, whatever you do, keep the same order and also give sufficient time to people to get the heart rate and blood pressure down to whatever was their baseline measurements. Okay? If they're taking medications, take that into consideration. Make sure you know if they can stop taking them before the test, or if they still take them during the test. Note, put a note down and make sure you take that into consideration during the test and when you're trying to interpret the scores. Of course, this anxiety is a thing. Give them time, white coat syndrome and stuff like that. You need to be cheerful and stuff like that, not stress them out. So whatever scores you get are very close to the actual scores. That's the point. And the emergency plan is the appendix B. You should know what to do just in case. Okay. Now, how can we achieve a comprehensive health fitness evaluation, right? We talked about the informed consent, pre-participation screening, pre-participation evaluation. Then you take the resting measurements. Then you get the circumference measurements and the body composition analysis, whatever you do about that. And then you do the health-related fitness tests. Have the cardiorespiratory fitness, muscular strength and muscular endurance, and the flexibility. Okay, now, which one? Well, it depends. The specific clients may have more risk than benefit if they perform a specific test. For example, 1RM. So you have to be very careful, and you have to decide on based on the case. All right. Let's talk about heart rate and blood pressure. The palpation is one way to do it. Osculation is another way to do it, or with an HR monitor, right? We've talked about that in 212. The blood pressure, that was a specific way how to do it in the previous chapter. Okay, body composition now. It is very important not only how much fat we have, but also where it is located, right? And if the fat is located around the abdomen area, right? This is, as you can see, related to many conditions. Now, some disturbing numbers: 2/3 of American adults are classified as either overweight or obese, and more than 1/3 are classified as obese. Okay, nearly 1/3 of American children, so pediatric data as well, are very disturbing, and adolescents are overweight or obese. Of course, as we get older, we lose muscle, right? Sarcopenia, which is of course is related to our body composition. So as we grow older, our fat mass is going up and our fat-free mass is going down. Yeah, usually we have that model that's a 2-compartment model. I already mentioned that is the fat-free mass and the fat mass, right? So whatever is not fat is included in the fat-free mass, and that's the model we have. It's not perfect, but and in general, we're going to see how we're getting those measurements. It really depends on the apparatus we can use or we can afford to use, but also our training and our skills, right? All right, so we usually start with the anthropometrics: height, weight. Then we can figure out the BMI, circumferences, and then skillful measurements. Very important, but also they can get technical. We'll talk about that in a little bit. And again, we don't have a lab, but if we had a lab, those were the kind of things we would just practice on, right? Excuse me. And then we have hydrodensitometry. So again, we're trying to figure out how much fat-free mass we have. Hydro means water, right? So underwater weighing. And plethysmography has to do with air. And we're going to talk about this in a little bit. DEXA, dual energy X-ray. DEXA is and TOBIC are techniques that we don't normally see in labs unless they can afford them. We're talking about huge machines that cost a lot. I haven't seen a TOBIC. I've seen DEXA a lot of times. And then BIA is the biological impedance analysis, but it really depends. Like when you go to a gym, you usually see that chip thing that we use for this, but they're way more expensive equipment to do the BIA. All right. So I hope we understand that we need a stadiometer to measure height. We need scale to measure weight, and then we can figure out the BMI. Okay, I've already asked you to figure out your BMI by yourself. That's important. It shouldn't be that hard, and it shouldn't be hard to figure out the BMI of your clients tomorrow. Now, in this table, which is important, we have a comparison between BMI and circumferences, right? Waist, to be more particular. So we've talked about the weaknesses of BMI, but the waist circumference shows us give us information not only about how much fat we have, but also where it's located. And we talked about why it is important to know how much it is located around this abdomen area, right? So waist circumference is a very good metric, and it's highly related to diseases and conditions. BMI, yes, but we talked about the weaknesses. So if we combine them, we get information from two measures, which is good, right? We triangulate it in a way. So remember, I hope you remember the numbers for BMI, and you can see the two numbers you have to remember about circumference is 102 for men and 88 for women. Okay, so if you combine the information, you can see what's the level of risk. Okay, circumferences. Okay, now we talked about location. We have android obesity, gynoid obesity. Make sure you understand that. In the visceral fat is the fat within our organs, right? It is highly correlated with medicine, metabolic syndrome, right? So it is important again. This is again to show how important it is, the location of our fat. Subcutaneous is below the skin, right? So Gallic tape is a classic tape we're using. Make double measurements, give enough time between the two measures so the skin can go back to its original length. This is how you do it. You can read that by yourself, nothing too fancy. What I want you to understand and remember is that you have to take those duplicate measures, like we said, and rotate. Don't forget that. All right, waist to hip ratio. We could talk about that before, but let's go over it really quickly. So we have a ratio, which is the circumference of your waist over the circumference of your hips, right? So you take those two and you get that ratio. The waist circumference could be enough. Another metric is the waist to hip ratio, which is great again, right? And you can see there's a positive correlation. So as the waist hip ratio increases, the health risk increases. All right. Now, what you need to remember, those two numbers, at least for young men and young women, is 0.95 and 0.86. Okay. You can see, as we said before, that the waist circumference can be used by itself, but if you use it with BMI, then we get a triangulation. So we may be getting the same information from two metrics, which is always comes out as more powerful, right? Okay, this is just for the waist circumference for women and men. Okay. Skinful measurements. Again, we talked about that in class. It's very accurate, pretty accurate when compared to hydrodensitometry. And hydrodensitometry, we'll talk about in a little bit, was supposed to be what used to be like the gold standard, right? Now uh, we're mostly using DEXA as the gold standard. Right here, the principle is that 1/3 of the total fat is located subcutaneously. So we're making those measurements of our skin, and we make there are different formulas depending on how many sites we're using, and using those formulas, we get a number like as a total, and we compare it with whatever standards we have, or you can just take measurements locally and compare them to a month ago or 2 months ago and see if you are progressing or not. Yeah, different regression equations. Regression equations are equations that predict something, right? So by putting those numbers there, it predicts your total fat. I hope you remember all this. I hope you remember we have diagonal folds as well, right? Right? I hope you remember. And what else? Always on the right side. Keep the pinch and rotate for the same reason you rotated with when you would use a tape. If there's a huge difference between two measures or measurements, you have to do it one more time. Factors that could increase the error. And calibers are very good in general, but not for people who have really low fat or really high fat. Densitometry. So in order to get the density of our body, we use the ratio of body mass and body volume. Right? And the difference between volume and mass, an easy way to understand that is volume is how much space we occupy, like how much space do I occupy right now, and body mass is how much. Usually we measure that in as a weight. Okay. Uh, uh, the best way to do it right now, with the gold standard, as I said before, is DEXA. Very expensive though, piece of equipment. Hydrodensitometry, that used to be the gold standard before, and as we enter the water, we push out an amount of water, and that helps us calculate our body volume. By calculating our body volume, then we can calculate our body fat and our body mass. In general, as you understand, body mass tissue is more dense, so it pushes out more water, right? So usually if you push out more water, that would mean that you have more mass, muscle mass. That's what I was trying to say. Now, that was great, but it created some issues, and not only a lot of space, you needed like a small area, like pool, right? It's a really small pool, but also people, didn't want to use a bathing suit and be in front of other people and stuff like that. So it could create some issues, and they didn't want to get wet, all these kind of issues. Plethysmography has to do with air displacement, right? So bot pod is an example. You've ever seen one? Pretty accurate as well. So these are some kind of conventional formulas, nothing too fancy, and I don't want you to focus on those. These are different skinful equations for men and women. Again, it really depends. DEXA is again as an X-ray. I've done DEXA measurements on myself a lot of times. It's pretty good and shows you also the bone density. Topic I've never seen. BIA, yes. What I want you to remember from BIA in general is that it has to do with water, right? As a conductor, in which cell contains more water, fat cell or muscle cell? Muscle cell. So the more muscle you have, the more water you have, which means the electrical signal that goes through your body will go faster if you have more muscle. And that's how this works. Those are some normative data. You can compare yourself and see where you are. What I want you to remember, and we usually get that a question. Actually, somebody asked me the other day, like, what's normal for a guy, right? So for men, as you can see, males 10 to 22, and 20 to 32 for women. Okay. Cardiorespiratory fitness, CRF. If you have low, of course, that's not a good thing. If you have high, of course, that's a good thing, as you can see, because it's associated with a reduction in all-cause mortality, right? And the assessment of CRF fitness is an important part of primary and or secondary prevention and rehabilitative programs. When we talked about the difference between primary and secondary prevention programs. So if you don't remember, look it up, please. VO2 max. VO2 max, we've mentioned it before, is the criterion measure of CRF, right? So through VO2 max, we can figure out your cardiorespiratory fitness level. And it can express in relative or absolute terms. And relative is per kilo, so we can compare that number between two different people. Absolute is not per kilo, so we can't really compare it with others other than yourself, if you went up or down. And VO2 max, it says here, is the product of maximal cardiac output, Q, right? And arterial venous oxygen difference. We've covered that before. Please, if you don't remember what that is, go back and study, okay? So open circuit spirometry, and usually called indirect calorimetry, is maybe you've seen it, we'll put a mask and the person just runs on a treadmill, for example. And as the person goes through whatever protocol, we can figure out their VO2 max, okay? Now, if we cannot have that direct measurement of VO2 max, one thing, what's the difference between VO2 max versus and VO2 peak? VO2 peak is usually the VO2 that, the maximum number of VO2 that you reach level. If that's not your VO2 max, that's your VO2 peak. It's a VO2 attained. That's a better way to word it. Sometimes we were going for VO2 max, but we didn't do that, or we had a client, a patient that shouldn't go all the way up to VO2 max. In general, we should go if we could, right? So sometimes we are trying to figure out the VO2 max based on the VO2 peak. That's what I wanted to say. If we cannot have a direct measurement of VO2 max, we can have maximal or submaximal exercise tests. Again, if we should go for maximal if we could, if everything is safe. If not, we should go for submaximal and then use it to estimate VO2 max. Okay. As you can see, maximal tests require participants to exercise to the point of volitional fatigue. All right. Those are just some conditions, the assumptions to estimate VO2 max, two submaximal exercise tests. Nothing really fancy here. When do we terminate? So sometimes we have a predetermined number. As you can see, the ones, for example, we did for ACSM, and I mentioned them before, we had the 85% of age predicted HR max. So we'll find the HR max based on the formula, and we would stop them at 85% because for safety reasons. Yeah. Okay. The Borg scale, we can use the Borg scale, right? It's from 6 to 20, or the modified from 1 to 10, but this is the most common one. These are some general indications. You can read them by yourself, nothing, again, that you shouldn't understand. We talked about drop in systolic before, or too high blood pressure. That's another one. All right. Now, how can we test CRF? Many ways. Field tests outside if you can, motor-driven treadmills, ergometers, and steps testing. So for the field tests, we have the first two are walk-run tests, which means very popular. The clients can either run, walk, or walk and run. The first one is how much time they need to cover 1.5 mile. Cooper 12-minute test is about how much distance they can cover in 12 minutes, right? And then we also have very popular the 1 mile fitness walking test, just walking, and the 6-minute walking test, which again is walking. And the first one, the Rockport, is about how much distance, and the second one, how much time, and the second one, the 6-minute walking test, are how much distance you can cover in 6 minutes. We have a single stage test and multi-stage test. Data rhyming is a single test, and the YMCA, for example, is a multi-stage ergometer test. These are some general procedures for testing. I'm not going to go over that. This is an anagram that you can use by yourself. In general, you can see on the right side, for example, that is different for men and women. And if you know the pulse rate on the left, the heart rate on the left, you can draw a line from the left side to the right side, and then you can figure out the VO2 max. Right? And there's some adjustment in our book that you will see based on age. This is another way to do it. If you do submaximal tests, then you can push your clients all the way to maximal. If you have 2 points, as you can see on the left side, that are submaximal, then you can just draw the line and figure out their maximal. Treadmill tests, very popular in the US. Depends on how many stages again. We'll talk in chapter 5 for some treadmill protocols. These are step tests. I don't necessarily want you to remember a lot about them. They're different based on how you figure out the cardiorespiratory fitness level and the height of the step and the rhythm that you have for sure. Now, interpretation. You compare your score to the norms, whatever norms, okay? And as we said before, there's the book, nobody is going to ask you to remember them, but when you have those scores, usually, like that's what I do, I have an Excel sheet that I have the formulas in there, and I just put the numbers and I get the number that I need based on age, sex, and so on. Muscular fitness. So muscular fitness is, I hope you remember, muscular strength and muscular endurance, both of them health-related components. Okay, and they're important because they can improve or maintain bone mass and muscle mass, right? And if you don't remember what osteoporosis or sarcopenia are, please look them up. Also, glucose tolerance. So glucose intolerance is something we're trying to avoid. Glucose tolerance, in a very simplistic way, is how much glucose we can actually use in our muscle. If we don't use it, it just stays in our blood. That's not good, right? Intolerance is not a good thing. We're trying to avoid that because that has to do with diabetes and prediabetes. It also improves it improves the risk for low back pain, right? Or also the risk of falling, and increases quality of life because we can carry out the activities of daily living. And also, the more muscle we have, the higher the resting metabolic rate. The higher the resting metabolic rate, um, the more calories we spend, which has, of course, to do with weight management, no matter what we're doing. This is what we usually call muscle strength, and this is what we usually call muscular endurance. Strength and power are not the same. We've talked about it. Power is about time as well, right? You, how much weight, let's say, you move from A to B in a second, a minute, or whatever. Right? Power is about time as well. How much force you can exert per unit of time. That's a very nice definition. So why would you do all this kind of testing? Well, you get a lot of great information. You know where you started from, baseline. You can compare to the standards, right? Standards not only to yourself, but to the norms that we have. And we can use them to design our programs. So we'll get a lot of great information. Of course, there are some principles. If I'm doing a 1RM test, of course, that has to do with my chest, right? Yeah, it's the specific. That's the principle of specificity. Also, has to be specific warm up. They need to understand the equipment. They need to know the posture and the form, right? The speed of the movement has to be consistent. So when I'm doing a 5RM, if it's a 2 second concentric, right? It always has to be 2 second concentric. Full range of motion, and of course potters if we need to. And again, there's difference between absolute and relative values. Relative are always very kilo. Muscular strength, the most classic ones, right, are the 1RM tests that we use, or some kind of grip strength test. And they can be static or dynamic. This is 100 gauge set strength procedures. These are some fitness categories for grip based on sex and age. This is a protocol for 1RM, and we always should use the same protocol, right? Every time we're doing 1RM. And these are fitness categories uh, for men and women by age. You don't have to remember those. They're just normative data that you can compare and contrast, and you know where you are. All right, endurance. Endurance is the resistance to fatigue, right? And the two tests that we used to use, and I want you to remember that, was the push-up test and the curl-up test. We don't use the curl-up test anymore because it's dangerous, and we figured out that it doesn't really give us enough information for this area, right? It's not a very good test. So we just kept the push-up endurance test, okay? This is how you do it, and this is how you can compare by age and sex. Flexibility, the last part of the health-related test, right? Ability to move a joint through its complete range of motion. And you can see the variables that it could affect that. Distensibility has to do with the pressure in the capsule, warm up, and muscle viscosity. And warm up, of course, you decrease muscle viscosity, which increases muscle flexibility and the tightness. Let's say if you did legs before, the day before, that should or will affect your flexibility levels. And how do we do that? Through a goniometer. That a goniometer is an apparatus that can really give us information about angles, right? So we put it there and we can see the degrees and the sit and reach test. These are some some ranges that they are expected, right, for single joint movements. And we talked about the Canadian trunk full flexion, right? That's the so-called sit and reach test. We've gone over this before. Remember, no shoes. You have to stay in that position for 2 seconds. You can warm up. You keep your knees extended, stuff like that. And this is how you compare it to the norms. And that's it for chapter 4. I'm gonna go ahead and share chapter 5, if I can. Let me see. Share. There we go. All right, so here we move from the fitness tests to the clinical exercise test, okay? And that's something that it won't happen a lot unless you're in a specific facility that they do that, right? And as you can see here, it is part of differential diagnosis. For patients with suspected ischemic heart disease, and ischemia, we talked about that, is restricted blood flow. Restricted blood flow. So we have disease that comes from restricted blood flow to which organ? The heart. So that's what we're going to talk about. And that's why we usually do this clinical exercise testing, because it gives us information when we suspect ischemic heart disease. Okay. And you see there that we can see graded exercise test. It can be called exercise stress test, is the exercise tolerance test, cardiopulmonary exercise test, and so on and so forth. Okay. All right. Diagnosis. That's indication for clinical exercise encompasses three general categories. First one, diagnosis. Prognosis. And the difference between diagnosis and diagnosis is we're trying to figure out what we have, right? Prognosis is what's going to happen in the future, 5-year prognosis, 10-year prognosis, or just evaluation of the physiological response to exercise. All right, so here, I don't want to go into a lot of detail. There's a lot of detail in this chapter. I want you to go all the way to the right. So the right column, you see they're asymptomatic. So if you're asymptomatic, the pretest likelihood of ischemic heart disease is very low to low. Okay. Now, the second from the right and the third from the right columns used to be compiled in one, but that had led to a lot of invasive tests that weren't necessary. So now we have differences if it's non-anginal chest pain, right? And there are ways to figure that out. It's out of, it's not important for us to know that. So if it's non-anginal chest pain, we don't have to do any kind of invasive exercise tests and so on and so forth. So you can see there's a lower risk compared to the third from the right column. We'll have atypical, probable angina pectoris. Right. So as we move from all the way from the right to the left, the risk, the likelihood, the pre-test likelihood, so before the test, of ischemic heart disease becomes higher. All right. Okay. Here I don't want to go into detail, but you can see there are different classes, right? And you can see how they're different, the circumstances. So just read it once. I don't want you to know more about that. Contraindications should be considered. We should know the test protocol. We should know the indicators to stop it, safety, medication, and all kind of preparedness if something happens, right? So everybody needs to be educated and trained. I'm not going to go over those contraindications. We've been over them before. You should know all of them. I hope you remember that absolute are more severe than relative. Okay. So, excuse me. So lately we have non-physician professionals. So, for example, clinical exercise physiologists that can take part in this kind of testing. They can administer actually this kind of testing, and it's fine. It's fine as long as they know up to like they understand what is part of their profession and what is not, and as long the physician will provide the final interpretation. Okay, those are the skills required. Nothing fancy here. Now the testing mode, it really depends. Treadmill, really popular in the States. Bike cycle ergometers, really popular in Europe. There are others such as steps. Now, what do we use to monitor it? There are many kinds of different apparatus that we can use for clinical exercise testing. As you can see, heart rate, ECG, cardiac rhythm, blood pressure, and so on and so forth. I just read you once to have an idea. Okay, that's the board scale, the modified board scale from 0 to 10. Okay. This is an angina scale that you can show them, a claudication scale, and a dyspnea scale. All right. Now, the gas is really important, especially cardiopulmonary exercise testing. So it can really give us important information. You have to be trained to do all this, of course. Oh, and determination criteria, that's what I want to tell you. That when the goal, as you can see, is a symptom-limited maximal exercise test, we shouldn't have a predetermined intensity. Okay, so what does it mean? I said before that when we did our testing in our lab, we had an 85% of HR max as the intensity that we should stop the individuals. So they would take them through the protocol. If they could finish the whole thing, great. If they would reach 85% of the HR max predicted, we would stop them. Okay. Here now, you stop them based on a symptom. So you're not looking for specific intensity. You're looking for symptoms. If you see those symptoms, that's when you know that you should stop the test. Okay, that's the difference. Absolute indications more important than relative indications. I'm going to talk about the ST elevation in a little bit because that is important. That's something I want you to remember. Of course, it is important to know the safety procedures during, but also after the test. And a lot of issues may happen right after the test. So we need to be ready and trained. Nothing really here. Heart rate responses, that's what you should expect. So that's why you should know. With increasing workloads, 10 beats per minute for 1 minute. So when the intensity is going up 1 minute, you should expect about 10 beats per minute to go up, of course, right? So you see the beta androgenic blocking agents as beta blockers, which reduce blood pressure, reduce heart rate. So you should know what's going on with those if they take them in. Because if they do during the test and the heart rate is not going up as you are expecting it to go up, then maybe it makes sense because they're taking beta blockers. What else? The rate of decline in heart rate following exercise provides independent information related to prognosis. Okay. As you see above that, among patients referred for testing secondary to IHD, and in the absence of beta blockers, failure to achieve an age predicted HR max equal or above 85% in the presence of maximal effort is an indicator again of chronotropic incompetence. And we talked about chronotropic incompetence. If you don't remember what it is, we talked about it last week and last semester. Go look it up again, okay? Blood pressure response, SBP should increase about 10 milliliters of mercury per met. DBP, nothing really happens there. Some other responses, hypertensive. You should know what's hypertensive. You should know what's hypotensive. And bladder response, we haven't covered that yet, is when it does go up, but it doesn't go up as expected when we're expecting it to go up. So it's like, yes, but no, right? And RPR, the double product, is the product of HR and SBP. Okay, so ECG. I threw in this picture so we can talk about it a little bit. PQRST. That's how it looks like. And also you see those specific segments, right? You see the PR segment, the QRS complex, and the ST segment. You see that if everything is as expected, there's a straight line that goes through the PR segment and the ST segment, right? Okay, so in a little bit, we're going to talk about ST depression, lower than that, ST elevation, higher than that. And that's really important. We have figured out that those differentiations in the ST segment are indication of issues, cardiorespiratory issues, cardiac issues. I'm sorry. So this is what we talked about, and this is what we should expect to see, and that's the most we will talk about in ECG, right? Is the J? Yeah, the J joint is where the S and where the ST segment starts. Okay, because this is not there. Okay, that's the J point. All right. So as you can see here, and that's what I want you to remember, ST segment changes are widely accepted criteria for myocardial ischemia and injury. However, the interpretation of ST segments may be affected by the resting ECG configuration in the presence of digitalis therapy. So when you're taking meds, if you're having some cardiac issues, right, that may affect that. Also, the way your ECG looks like after or during those tests has to be compared to how it looked like before. Okay. What else? I don't know. Have we covered how Parkinson? Why it is? It's an electrical issue in your heart. It beats a little bit too fast. To be clinically meaningful, ST segment depression or elevation should be present in at least 3 consecutive cardiac cycles. Okay, the thing that I just showed you, the figure, that's 1 cardiac cycle, right? And now we also have horizontal or downsloping ST segment depression. So I'm going to talk about it in a little bit, but that, if it's more than 1 millimeters, sorry, and at 80 milliseconds after the J point, as you can see, that's a strong indicator of myocardial ischemia. And also we have post-exercise, that's another one, that's another indicator. If you have a depression at a low workload, that's even worse, as you understand. That gives you even worse prognosis, right? So if you get that reaction from a low workload, that's not good, right? And when ST segment depression is present in the upright resting ECG, only additional ST segment depression during exercise is considered for ischemia. So you need both. That's a little bit too much for this class, but I want you to remember this. So if we have a depression in all 3 cases, as you can see on the right. The first one is upsloping, and the second one is downsloping. So that's how it would look like. So there are different kinds of ST depressions, ST segment depressions. Nothing really here, no. Okay, any symptoms should be noted, of course. Exercise capacity is another thing. And of course, the more capacity you have, the higher the level of your cardiorespiratory fitness. Okay, so if you can do more meds, that's better. If you can do less meds, that's not a good indication. Okay, this is a prediction of peak VO2 based on sex. as well, and age. It's a lot of information. I don't want to confuse you here. Not really. Okay, yeah, that's pretty much the last thing I want you to remember from this chapter. Sensitivity versus specificity. And it doesn't just have to do with this kind of test, any kind of test, right? So sensitivity is to identify somebody who has something. And positivity is to identify somebody who doesn't have something, even a pregnancy test, right? So we need to figure out, or a COVID test, right? The PCR test, or what's the other one? The rapid one. Okay. So we need to know how many of those who test positive are truly positive and how many of those who test negative are truly negative. Some tests are great with sensitivity, but they're really poor with specificity, or the other way around. We need tests that really identify patients who are truly positive and patients who are truly negative. Okay, I hope that makes sense. So here we have some formulas. In general, we need to know the percentage of positive tests that are correctly identify patients with IHT and the percentage of negative tests that correct identify patients with IHT. That's what I want you to remember. This is the sensitivity, and this is the specificity of tests, okay? Because those tests are trying to make a diagnosis, diagnose something. We need to know if they show that I have something, I truly have it, or if they show that I don't have something, I truly don't have it. Okay, and that this is about any kind of test. So this is very important for you to remember, and it applies on a lot of things. Yeah, no. Okay, so I'm gonna end here, and we're just over 1 hour, which is great because that's what I'm trying to achieve every time. And make sure you submit the LOs that you have for this Sunday, right? Make sure to remember that we don't have any synchronous meeting this week, but we do have office hours tomorrow from 8 to 12:30. If I don't see you tomorrow, I'll send another video next Monday, right? In the meantime, lift intentionally. No habits left.